Welcome back to the deep dive. Our mission today is very laser focused.
It is.
We're doing a comprehensive deep dive into critical ENT clinical knowledge. We've structured this specifically for medical learners who really need the clearest, most actionable summary.
Exactly. We're pulling out the core knowledge you need for those high-stakes clinical settings.
Viva training, essentially.
Yes, exactly. And it's not just about technical excellence, knowing the steps of an ear exam. It's also about those crucial non-technical skills.
Like consent.
Like understanding the nuances of informed consent in really complex cases.
Okay, let's unpack this. Before we get into any of the complex pathology, we have to start with the non-negotiables.
The foundational pillars.
Right, because if you don't master the etiquette and the structure of the examination, the rest is almost irrelevant.
It's all about professional presentation and, of course, patient safety. First impressions matter.
So you need to present smartly.
Consistent with normal clinical practice. And there are two big hygiene rules that, often trip people up. The bare below the elbows rule. That's vital for infection control. And if you're wearing a tie.
Oh, the tie.
It absolutely must be tucked into your shirt or secured with a clip. It just can't touch the patient.
And we often hear about the one cardinal rule in any clinical setting. Remind us of that absolute non-negotiable.
It's so simple, but it's paramount. Under no circumstances must you hurt the patient.
Full stop.
Full stop. If something is causing undue pain, you stop, you explain, and you readjust. And of course, mandatory alcohol hand gel before and after every contact.
Now, a key test of knowledge is differentiating between, say, a narrow prompt and a broad one. Can you give us a classic example?
Yeah, the crucial distinction is between examine the thyroid gland and examine thyroid status.
Okay.
If you're asked to examine the gland, your focus is local. Inspection, palpation of the neck.
But status is different.
Status is the whole system that immediately demands a full general physical. You're checking the pulse, skin quality, and critically the reflexes. It tests if you understand that endocrine disease affects the entire body.
That makes perfect sense. And what about managing time? In an exam, you're always rushed.
You have to verbalize your full intent, always. So if you're examining an ear and the examiner stops you, you have to say...
What you would have done next.
Exactly. You say, in a complete examination, I would also perform pneumatic otoscopy, tuning fork testing, and clinical hearing tests. It shows you know the full scope, even if you can't perform every step.
Let's move to that systematic approach then, the ear examination. What are the precise steps?
Methodical sequence is everything. First, clear access, glasses off, any hearing aids out.
Then inspection.
Inspection is key. Look specifically for post-auricular or endoral scars, any pits.
And then we move to otoscopy. What are the structures you have to identify?
Otoscopy covers the external canal, the tympanic membrane, the TM, and you have to look at the entire surface, including the attic.
Okay.
And then you're looking for the ossicles. After that, you've got your specialized tests, pneumatic otoscopy for TM mobility, and the tuning forks.
Weber and Wren.
The classics.
And to put those tests in context, we need to understand the intensity, right? The decibels involved.
Yes, because it helps you ground the functional hearing loss. For instance, a whisper at about 6 inches is roughly 34 dB.
Which is really quiet.
Very quiet. Whereas a conversational voice at arm's length, maybe 60 centimeters, is about 48 dB. And this matters for the tuning forks.
How so?
Well, if a patient is severely deaf, they might not even perceive the vibration from the fork because it falls below their hearing threshold. That makes the test invalid, and it tells you something right away.
Okay, let's pivot back to the neck, the thyroid examination, but specifically those remote signs you mentioned.
Right, so beyond inspecting the swelling and palpating the gland and lymph nodes, the remote assessment for thyroid status is mandatory.
So you're checking the eyes.
Checking the eyes for exophthalmos, lid lag, checking the hands for a fine tremor or skin quality changes.
Right.
And you have to take the pulse.
And the classic reflex assessment.
You check the deep tendon reflexes. The classic sign of hypothyroidism is those slow, relaxing reflexes. And you also note any proximal muscle wasting, which surprisingly can occur in both hypo and hyperthyroidism.
It's that systemic detail that really separates a good clinician from someone just running through a checklist.
It is.
Let's shift our focus now to pediatric pathology, starting with something very common, acute otitis media, AOM.
With AOM, you need to know the 3 most common bacteria.
Which are?
Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis. That knowledge guides your antibiotic choice, if you need one.
And that's a big if, right? The philosophy isn't always immediate antibiotics.
Precisely. AOM is often self-limiting, so we can practice antibiotic stewardship.
Yeah.
For older kids with uncomplicated infections, the standard approach is just to wait and watch for 48 to 72 hours.
But you'd abandon that for high-risk kids.
Immediately. If they're under 2, have recurrent AOM, severe symptoms, or any immune deficiency, they get antibiotics right away, no question.
And what are the key complications we need to be aware of? The scary stuff.
We categorize them by location. So intratemporal complications would be things like mastoiditis or facial paralysis.
Or intracranial.
Much rarer, thankfully, but catastrophic. Meningitis, brain abscess.
Okay, moving on to otitis media with effusion, or OME, glue ear.
Yes, and certain populations are highly susceptible here.
What are the big risk factors?
Common ones are parental smoking, daycare, bottle feeding. But we really have to pay special attention to children with Down syndrome and particularly cleft palate.
Why cleft palate specifically?
Because the underlying structural defect causes severe ongoing eustachian tube dysfunction, so they get earlier, more persistent, and recurrent OME.
Does that high risk change the standard management? Because usually we think of grommets for OME.
Yes, it dramatically changes it. For the cleft palate population, the recommendation is actually to offer hearing aids as the first-line treatment,
Over grommets.
in preference to repeated grommet insertion, because of the high recurrence rate and the risks of multiple surgeries.
That's a really important distinction. Let's talk airway laryngomalacia, the most common cause of neonatal stridor.
Right. Presentations usually around 4 to 6 weeks of age. You hear this high-pitched, fluttering, inspiratory stridor.
And it gets worse with certain activities.
Exactly. It's characteristically worse when the baby is supine, crying, or feeding.
And what's actually happening? What do you see on endoscopy?
You see anatomical parts that collapse on inspiration, a long, curled, omega-shaped epiglottis, and bulky aryepiglottic folds that just fall inward.
So what's the management?
The good news is it's overwhelmingly conservative. Over 90% of cases just resolve on their own by age 2.
Is there any supplementary treatment?
Often anti-reflux medication. Reflux is very common alongside it and can make the stridor worse. For the very rare severe cases, surgery is an option, a supraglottoplasty.
Okay, that covers some key pediatric issues. Let's transition to neck masses, starting with thyroglossal duct cysts, or TDCs.
The origin of the TDC tells you exactly how to treat it. It's from the persistence of the tract during thyroid descent in the embryo.
And if it gets infected.
The critical instruction is to treat with antibiotics. You must avoid incision and drainage if possible,
Why is that?
because it dramatically increases the risk of creating a chronic sinus or a fistula, which is a much, much harder problem to solve long term.
And when you do need surgery, it's not a simple excision. The gold standard is pretty radical.
It has to be. You have to remove the entire embryological tract or it will come back. The gold standard is the cyst trunk procedure.
And that involves?
Removing the cyst, the full tract, the central part of the hyoid bone, and even a wedge of tissue right up into the tongue base.
You have to take part of the bone out.
If you don't remove the hyoid bone, recurrence rates can be over 50%.
Wow. Okay, another dramatic mass. Juvenile angiofibroma? JNA. Benign, but clinically aggressive.
Classic presentation. It's almost always an adolescent boy, median age of 14. And the symptoms are severe, recurrent epistaxis, and nasal obstruction.
And this leads to a critical diagnostic rule, one where you have to suppress your natural instinct as a doctor.
You mean the biopsy? It's right. Absolutely. Biopsy is completely contraindicated. It carries a catastrophic risk of severe hemorrhage.
Why is the bleeding so bad?
The tumor is basically a bag of blood vessels that don't have the normal muscle to constrict. Any attempt at a biopsy could be fatal. So diagnosis is all on imaging, CT or MRI.
And that will show the classic sign.
The Holman-Miller sign, which is the bowing of the posterior maxillary sinus wall.
So management is surgical, but with a crucial preoperative step.
Correct. Primary treatment is excision, but pre-op embolization is standard practice. It cuts off the blood supply to the tumor and makes the surgery much, much safer.
This is where it gets really interesting for me. Shifting to neuro-otology, acoustic neuroma.
Vestibular schwannoma, yeah.
The surgical choice here involves these complex, calculated trade-offs.
It's a decision matrix, really. It depends on the patient's hearing, the tumor size, and their goals. There are 3 main approaches.
Let's start with the one that's best for the facial nerve.
That's the translabyrinthine approach. It gives you the best exposure and preservation of the facial nerve.
But there's a huge trade-off.
A huge one. The trade-off is complete, permanent hearing loss in that ear. You have to destroy the inner ear to get to the tumor.
So that's for patients who already have bad hearing.
Exactly. Non-serviceable hearing.
Okay, what about the approach that offers a chance of saving hearing?
That would be the retrosigmoid approach. It offers a possibility of hearing preservation, maybe 30 to 65%.
What's the downside there?
The drawback is that it requires cerebellar retraction, and there's about a 10% risk of a persistent post-operative headache.
And the final one, for very small tumors.
That's the middle fossa approach. It's for small intracanalicular tumors, and it has the highest rates of hearing preservation.
But it's difficult.
Very technically demanding, and it carries a risk of temporal lobe retraction, which can lead to epilepsy.
Epilepsy.
Yes. And if that happens, the patient usually needs a year of anticonvulsants and can't drive. It's a significant potential complication.
It's just profound how you have to weigh access, risk, and function. Okay. If we connect this to the bigger picture, technical brilliance has to be matched by these critical non-technical skills.
Yes. Ethics and consent.
This is where we shift to the legal guidance from bodies like the GMC.
Right. And the general rule for treating a child is you need consent from a competent child or a parent.
Let's define competent child, though.
We're talking about Gillick competence, the standard where a young person under 16 is deemed capable of understanding the treatment, the consequences, the alternatives.
So what happens if the competent child and the parent disagree?
This is the critical nuance. If the young person is competent and consents to a treatment that's in their best interest, the parents cannot override that consent. The child's decision stands.
Okay, but what if it's the other way around? The competent child refuses life-saving treatment.
That's where the law gets much more complex. In England, Wales, and Northern Ireland, if a competent young person refuses a life-saving intervention, a parent or doctor can seek legal advice and involve the court.
Because preserving life usually overrides their refusal.
Usually, yes.
Yeah.
It's about the child's best interests in that very specific context.
And then there's the exception to all consent rules, the emergency.
Correct. Emergency treatment can be given without consent from anyone if it's immediately necessary to save the child's life or prevent serious, irreversible deterioration.
Which brings us to that classic ethical scenario. The 12-year-old with a post-tonsillectomy bleed, HB is 6, actively bleeding, and the patient and father are Jehovah's Witnesses refusing a blood transfusion.
You have to respect their views, you have to engage in dialogue, but the emergency exception dictates the path forward.
You give the blood.
You can and you must provide the necessary blood transfusion without consent if it's required to save that child's life. The duty to act in the child's best interest in a life-threatening emergency overrides the refusal.
This deep dive has been incredible. We've gone from examination structure to the surgical trade-offs of neurootology and this tightrope walk of pediatric consent.
It's a blend, isn't it? Technical knowledge and essential ethical literacy. You can't have one without the other.
So to wrap up, here's a quick review exercise for you. Based on the GMC guidance we just discussed, if a 14-year-old boy deemed Gillick competent refuses a necessary tonsillectomy for severe infections, can his mother override his refusal to make him have the surgery?
This is a critical test of understanding.
Yeah.
And the answer is no.
Yeah.
No. If a competent young person refuses treatment that is not life-saving, their refusal generally can't be overridden by a parent. Parental override usually only applies when the child consents to treatment or when a court steps in over a life-saving issue. His competent refusal for an elective procedure must be respected.
That's such a clear, important distinction.
This raises an important question. We've talked about complex head and neck surgery. Consider the steps a surgeon has to take when managing exposed vessels in a field that's been previously irradiated. The risk of a carotid blowout is greatest more than 6 months after radiation. And failure to cover those great vessels with a muscle flap drastically increases the chance of a catastrophic outcome.
So all about prevention.
It's all about anticipation, ensuring you have a robust, vascularized muscle flap to cover those vessels to prevent erosion and tragedy. That constant anticipation, that's what defines great head and neck surgery.